Maybe we'll just go ahead and get started in the interest of time, and hopefully Dennis will catch up. Since we have a new person on the phone, Marguerite, I don't know if you're back. Maybe we want to do a quick, okay.
Hi,
do we
sorry
want to, no worries, welcome. Do we want to do a quick round of introductions just to refresh and introduce Marguerite to the group and the group to Marguerite? Okay, Jennifer, why don't you start with you?
Hey, this is Jennifer Strickland. I'm the Experience Director for Lakewood Health System in Staples, Minnesota.
Who wants to go next?
I'm Tracy Smith. I'm with Southern Illinois University School of Medicine in Springfield, Illinois.
Hi, this is Renee Boak, Director of Integrated Health Services at Cascadia Behavioral Healthcare in Portland, Oregon.
This is Susie Boucher. I'm the Assistant Director of Centralized and Managed Care Services at Alta Point Health Systems in Mobile, Alabama.
Durin? Durin, do you want to introduce yourself?
He might have stepped away. This is Susie. Seren is in our IT department. He's one of our, does a lot with programming. I don't know his exact title.
Cool. Hi, Susie. Thank you. I was just dying.
Sorry, Seren.
No, thank you. I'm running late.
Okay. Marguerite?
Hi, I'm Marguerite Tuthill, and I'm the Planning Analyst for the California Critical Access Hospital Network.
Okay. So we're missing Dennis from Dental Aid. Why don't we do a quick round of introductions for the Optum folks? I'm Natalie Ellerson. I work as part of this team that's on the phone here with you from Optum. We run Medicaid ACOs, primarily comprised of safety net organizations.
I'm new to the call this week. I missed everybody 2 weeks ago. This is Carol Dahl, and I'm on Natalie's team with Optum. And heard you had a good first session. Looking forward to a great second session today. Hi, everybody.
Hi, this is Rachel Pettis. I'm a licensed clinical social worker on Natalie's team. I help with ACOs also.
Jerry? I wonder if Sherry's on mute. Oh, okay. She's saying I'm here, and the wonders of technology. We still can't hear you, Sherry. Sorry. Okay. Why don't we just go ahead and get going? So, brief introductions. We just went through those. In a minute, we're going to ask you about your homework and how your contract analysis went. But then we'll spend the remainder of the session talking about how to begin creating a clinical management program. And, you know, oftentimes the place to start is with high-risk case management. When you know nothing else about your population, you can always come up with some kind of definition of what high risk means. And then we're going to talk through some common strategies for identifying patients who have higher than average risk. And then we're going to talk through an emergency department reduction management program. You know, it's like we said last time, a lot of this, I know this is going to sound crass to those of you working in very mission-driven organizations, but you know, value is in the eye of the beholder. In this case, the beholder is typically a payer. And what a payer is looking to accomplish when that payer works with providers, regardless of what types of providers, is to help reduce overall total cost of care. So This is about following the money, and one of the goals will usually relate to cost savings in a value-based arrangement. The other will relate to quality. Hopefully there's a third or fourth around patient satisfaction, improvement, and access. So anyway, we're going to, in this session, last session we took a look at some sort of typical constructs in value-based payment. This session we're going to start to think about, given goals for value-based payment contracts, how do we start to parse who's in the population and identify the people we want to engage with to meet our contractual goals. So then there is also another homework assignment. So Marguerite, you're kind of new to this. You have a colleague there. I don't know if you worked on the homework assignment over the last couple of weeks together or whether you let your colleague just kind of do what she was going to do, but each session within the Learning Collaborative here comes with a little piece of homework. We don't expect you to spend an exorbitant amount of time on it. We know you all have day jobs, but it's just to get you to think about and apply the concepts that we've presented during the bulk of the session. So, go ahead. Someone have a comment? No. Okay. So just a couple of housekeeping logistical items. Thank you for logging in early. We really appreciate that. Again, please stop us if you've got questions. This is a little different from the way we normally engage with others whom we work with. It's really missing kind of the body language and facial cues and maybe puzzled or furrowed eyebrows when we introduce new concepts or when something we're saying doesn't make any sense. But, please jump in, and, if there's anything we say that doesn't make sense or seems counterintuitive or just alien, please stop us. And you can always email Carol Dahl here at Optum.com anytime between sessions, and Carol is our wonderful triage person here to help get your questions answered and get you any other support you may need to get through this and meet your learning objectives, which include understanding what a clinical management model is and why it matters in your value-based contract. We'd like you to be able to parse a value-based contract and think through, at least understand at a high level, the implications for your organization. And then we'd like you, by the end of the Virtual Learning Collaborative, just a refresher, to be able to put together a plan for making the kinds of changes you need and your organization needs to be successful in value-based contracts. And that means coming up with and supporting a clinical management model which has all kinds of implications for people, process, technology, policy in the environment in which you work. So, Marguerite, just a little refresher there. I don't know if you had any time with your colleague prior to this session to kind of review what happened during our first session. Were you able to? Marguerite?
Sorry, can you hear me?
Yes. Uh-huh.
Oh, okay. Yeah, I just had like a very brief review of what happened last time, and I have the slides.
Okay.
Yeah.
Great. All right. So before we get into today's objectives, which are around, thinking through clinical management program components and coming up with an identification stratification method, so to find your proverbial needles in haystacks, let's talk about our homework a little bit. I'm just going to step back. So the homework we had last week was to look at a two and a half page term sheet, remember? And to jot down your thoughts about whether or not ultimately that term sheet, which is an abstract of a contract, presented your organization with a good deal or a bad deal. Is it something you'd recommend to your board of directors? Why or why not? And then what information would have been more helpful in coming to some kind of a determination about how to respond to that contract? So I'm going to pick on Jennifer Strickland and see, Jennifer, did you have a chance to kind of look through the homework assignment, spend a little time with the term sheet, and would you be willing to share your thinking with regard to the term sheet?
Absolutely. So I did. I apologize. I had to step out of our last session. We had something that needed my attention, so I had one of our experienced representatives kind of listen in. But I did go through the term sheet, and I just kind of jotted things down as I went through. And some of it does seem a bit of a different language. So as I went through, I thought, wow, is this confusing or purposefully vague, or is it just my own ignorance? So I'll be completely transparent right there and say I'm not sure which it is, but we'll own it either way.
Oh, well done, Jennifer. Great.
So how's that for being like not self-deprecating but completely honest? There's a couple of things that jumped out at me as I looked at this. Just again, I'm a registered nurse by background and not fiscally minded per se. But, some things that's, quarterly this is going to happen, and then that's going to be yearly, and then it's 24 months for a contract, and then it talks about how they're not going to have the final numbers up to 18 months afterwards. So part of that seemed, and I don't know if that's typical for a term sheet, or if that's kind of a long time. That was just one thing that jumped out, that I liked that the first year you had a chance just to report and to really monitor, and then it was the second 12 months that you actually worked to make adjustments. I liked that part of it because it gives you a chance to see where you're at as an organization. One thing, and if you're starting on the first page and you go down about 4 columns, that gain sharing definition and payout, when I talked about savings occur when the target total cost of care for the attributed patient population is below trend, and risk adjustment, and I'm assuming, is that trend our trend for the first year, or is that an industry trend? That was a little bit vague for me, and I wasn't sure. It's hard to say if there's like a benchmark you're going for within the entire ACO or ACOs across the country, and if you're really below that, that could really be challenging, or if that trend is our organization's trend, then it could be more attainable and something that you could work on as a team.
Very great catch. Great catch, Jennifer. Very good catch.
So that was one thing. And again, those varying timelines, like being attributed by provider versus by an organization, that too I think held more ramifications in a way that's great, because that allows us to go to each provider and say, hey, you're a rock star, you're doing great, or you really need to catch up. But again, I think that inherently means that as an organization, we would almost need one person dedicated or two to really track all of that, and then meet with those providers so that we could influence the outcome. I think those are just a couple of things that jumped out. Is that a good start?
I think that's an awesome start.
Oh, the only other thing I had jotted down is, as a critical access hospital, when they talked about holdbacks, you look at, you've got your benefit, but is that then risk dollars that you're also engaging in, versus you have, if you do really well and you get additional reimbursement, versus if you're holding back 25%, if I'm interpreting that correctly, that's a huge punch to a bottom line for a critical access hospital. So that seemed quite high.
Okay. So what information would have been more helpful to you in parsing that contract and figuring out if it's something your organization would want to take on or even entertain?
I think more of those definitions of when you're talking about below trend, that would be great. The other part, I don't know if it's more information. Again, I think for me, if I were working on this, I would need a lot of things defined better, getting more definitions to understand exactly what it is that we're going into. The part about like that clarifying, at what point are these dollars, like if they're saying they can have up to 18 months, to look at that to determine if there's a payout or not. That seems like a long time. And so what happens in the interim, is everything held, or is a certain amount gone through? So those are just some questions I would have.
Okay. So huge cash flow implications. You know, kind of a go step at a time towards withholds based on quality. Lack of specificity in some of the definitions. You thought it was a good thing that it was attribution at the provider level versus the entity level. Are there others who parsed this term sheet and came up with different conclusions, observations? Were you equally frustrated? Were you more frustrated? Was it a piece of cake?
So
Who else?
This is Tracy at SIU, and one of the things I felt was kind of measuring was an incremental measurement. There was really no starting point. So medication management of asthma, 50%. What does that mean? So if I'm at 45, 50% is not hard, but if I'm at 5, that's huge. So no incremental measurement increase necessarily. So I felt that there's a lot of uncertainty in the returns and accountability on the payer side for this contract. So I probably would not sign it as is at all.
Okay. What would be the major thing you'd want to see? What would be the top 2 things you'd want to see done differently, Tracy, in order for you to bite on this one?
Probably really to see what the payer's accountability is in this. So again, I have nothing financial, so I went and met with our value-based contracts folks at one of the local hospitals. And so it was a lot of discussion we had on there. But again, it came back down to he didn't feel it met the 3 checks, he says. And I saw what he was saying when he says there's the 3 checks that he uses for a value-based contract like this, that the incentives align. So the goals and objectives, can the purchaser equal what the provider can give, and can the patient equal those outcomes? And so he was, one of the big things that we talked about was how to do the patient engagement and tie that ability to engage in the behavioral aspect of it. And the second thing was, can the alignment occur in agreement of outcomes? So HEDIS, financial, per patient per month cost, and then do we have the resources to do that? So when he kind of went through those checklists, there was major areas missing in each one, it seems. So kind of like the incremental measures, the quality of the data provided, where was the baseline data coming from? The one big thing he didn't like and was the, gosh, I got to find it here, I'm sorry. There was he said he would not sign this mostly because, I'm trying to read my notes, I have scribbles everywhere. His biggest thing was his concern about, what is the penalty back to the person who's signing this if they don't end up meeting the what's called for. So he said there was no direct listing of the penalty and types and the directions that he would like to see and has seen in the past.
Okay. So I think there's another common theme here, devil's in the details. Yeah. What additional information other than definitions would you have wanted to see? Or what other structural issues would you have wanted to negotiate, Tracy?
I'm thinking.
Okay. While Tracy's thinking, anybody else want to share your observations on this exercise?
Hi, this is Renee from Portland, and I thought this was a great exercise, and I agree that a lot of the devils are in the details. I think my main concerns in looking at the contract was just the reporting timing, when we'd be getting information back from the payer and how they would expect it from us before even the quarters close. So I had concerns around the reporting structure. And I also had concerns around how the money is split after reaching the 1% threshold for saving. Not really knowing too much about that area, It seems like splitting 1% 50-50 between the provider and the payer seems quite high. And when I was looking at the contract goals, it was talking about how to incrementally improve care quality for attributed patients, but I didn't see a lot of information on how they were going to determine that. I think they spoke to, how to determine around, saving cost of care, and they provided some potential options, or at least noted that the PCP satisfaction rates are going to be validated measurement tools, but I didn't really see about how they're going to measure the cost of care. And of course, that's concerning to not know how they're going to be measuring that from the get-go.
Mm-hmm. Yep.
And I think the other point is, when it's talking about data sharing, I would also have questions around, it's talking about all the data that's, going to be shared between the ACO and the payer, but I didn't really see reference to 42 CFR, which is really big in the behavioral health world around sharing information around addictions. And that tends to be quite tricky. So I would have some questions or want some additional information around what data sharing would look like as it relates to being protected around sharing addictions information.
Okay. Any other comments, observations? Did this make you want to run screaming the other way? Okay. So I'll just share with you that this contract was, this term sheet, I should say, was modeled closely after the state of Minnesota's Integrated Health Partnership Program. And Jennifer, as a Minnesotan, you may be familiar with that. And this was kind of early on in the process. It's modeled on some of the earlier versions of the contract that the state released, when we were all learning a lot about many different aspects of taking on value-based contracts. And so, those of you who pointed to ambiguities, there is ambiguity. And the good thing about this process with the state of Minnesota is that we were able, as an IHP, working with our 10 FQHCs in the Twin Cities area, to negotiate a lot of the elements. For example, the state wanted to start with an absolute improvement in quality, and we started with an incremental improvement in quality. We were able to negotiate an incremental off baseline. I think somebody mentioned that there. Initially, and then some things that were negotiated were ultimately, we thought we'd negotiated, and they got reversed. For example, it's an industry standard in measuring patient satisfaction to work with a tool called CAP. And we had initially proposed a tool created by the Midwest Clinicians Association, and the state had first of all said yes, and then wanted a more common measurement framework, and said, nah, you got to go back to CAPS, which, was tough for a lot of our safety net centers because, CAPS is a very long form. It's often mailed out. It's like 10 pages. Some would argue that it's not terribly Medicaid friendly or cognizant of cultural and language barriers, even though it's written at a reasonable literacy level. But we all know that, a lot of our patients returned incorrect addresses are a big deal. So we get a lot of returned mail, and very few people are willing to sit still for 10 pages of questions written and then mail the survey back. So in terms of helping us get meaningful information about patient satisfaction, we were a little bit dismayed. But you brought up a point about alignment, which I think was very important. We also made some assumptions about alignment that ended up not being quite as accurate as we had foreseen. So we would have done well to have more discussions about alignment and how some of the practicalities, for example, data sharing, it seems like there would be great alignment between the state of Minnesota and its IHP's Integrated Health Partnership contractees in terms of disclosing lots of data. We got into the issue of data privacy, and not just CFR, but also some very strictly interpreted state-specific protections around data. And Jennifer, you may know them better than I do, such that there were things included in our total cost of care services, for example, chemical dependency-related services, where we would never get claim-level information for anyone about the nature of those services, yet we would be responsible for total cost of care. So you guys identified a lot of the issues. The bumper sticker is the devil's in the details, never settled for a term sheet. And, you already got to it. Ask lots of questions, have a lot of conversation. We spent a year negotiating our contract. Now, granted, this was a few years ago. We learned a lot from that. We hope that our subsequent processes and contract negotiations have been a lot more efficient. But it takes a lot of time. So as you think about getting into value-based arrangements and clinical management, don't underestimate the amount of time and the breadth of skills and capabilities needed on your team to really get through a good contract negotiation. Okay, so any more comments, questions about that exercise before we move on? All right. So there's something we've inferred here, and I just want to make it really explicit, and that is that we talked about value as being something in the eye of the beholder. And in the case of value-based contracts in healthcare, we're talking about what's valuable to payers. And a lot of you deal with a lot of Medicaid. It may be your single biggest payer, especially for those of you who live in expansion states. It's a significant payer, and it may be one payer, i.e. the state, or it may be multiple payers, meaning managed care organizations. But one of the skills that's important for value-based contracting and clinical management as a part of what's essential to effective management of risk-based contracts is analysis of a payer's itches or problems or whatever, and a good understanding of how they spend their money and on whom they spend their money, because it will give you good insights into what their goals are and whether or not you can align with those goals and whether or not you can act on those goals. So when we talk about Medicaid, I thought it would be interesting to look at how Medicaid dollars are spent today. So $500 billion program or so, give or take, 50 billion. Here's how the breakdown of spending occurs today per Kaiser Family Foundation. About a third of the spending is on long-term care, and that includes long-term services and support, some of them, not all of them. There's a big bucket of others, which is DME, transportation, interpretation. Not all payers are going to spend this much money on other services. If you look at a commercial payer, the mix will be completely different. I think it's notable that inpatient hospital is 23%. It's a quarter of all spending. Outpatient services, I'm not sure that includes emergency department services. And I think if you, depending on how you define some of these buckets, a big chunk of outpatient may be emergency department. I was surprised. I usually think of prescribed drugs as more like 15% or so of Medicaid spending. And within that, about 20% of that is antipsychotics. So does this surprise anyone? Do you ever think about total cost of care for a cohort and where your patients may be driving utilization and related costs? Is this kind of a new view of how money gets spent in a Medicaid program?
This is Jennifer, and we joined an ACO this past year, and the other organizations within our ACO, our big focus has been actually on that long-term care. That was just one area in looking at those dollars that specifically I think as a health system, we do have a long-term care facility that's within our system, but so many times you refer patients out and you really don't have as much control over that spending. So how, as an organization who's referring patients, how can we have control over that? And also the big debate too is long-term care facility versus, say, a swing bed, which with critical access hospitals, that's just a huge component that is we're so grateful to have and makes a big difference. But definitely when you're looking at the dollar side of it is a huge contender.
So as you were thinking about joining that ACO, did you do analysis that was similar to this, different from?
I would say similar. We seriously considered two different ACOs. One was more regional and centered in Minnesota, North Dakota, South Dakota, and Wisconsin as well. And the other was a little more, it was based out of Colorado, I think, and was more national. But yeah, we kind of looked at that portions of it, and really, I think until we joined, though, it was very theoretical. And then once we, dove in, we were looking at it more closely. And I think getting this data and truly then looking at the data of your specific patients is very challenging. You can kind of look at national trends, and then you look at your own trends, and to see if it lines up, and if so, like what your outliers are. So I would say this is similar. The prescription drugs part, I want to say ours might have been even a little bit higher. That one seems actually a little bit low. But again, it may depend upon your clientele.
Right. Yeah, I think this would look very different if you put Medicare at the top and, broke it out in these categories or similar categories for Medicare. You'd see even more drugs. I think this is low on drugs for Medicaid, but I think for Medicare it's even more significant. And you would see that long-term care reduced because Medicaid is usually the primary care of those types of services. So, this is something that's useful to do for each population and for each payer that you're contemplating engaging with. Now, the real reason we wanted to do this, though, is to say, you got to think about who you are in the healthcare ecosystem, what type of entity you are, what services you offer today. And to your point, Jennifer, where is the money being spent, and what can you affect and what can you not affect? Given the type of entity you are today, the services you offer, your relationship with these other types of providers, and what it is you're trying to accomplish. So we also wanted to show you this type of very rudimentary analysis as a basis for saying, okay, you're going to have to think about clinical management programming. The point of all of this isn't just to keep delivering more services the way you've been delivering them, but to think about spending on a population a little bit differently and what your organization specifically is going to do differently from a clinical management perspective to get after goals that are aligned, shared with a payer. In other words, how are you going to reduce costs and what are you going to do to improve quality? So another way to look at information is also to look at the people in a particular population, understand who they are, and understand what they spend in aggregate, and then what their challenges are to better health. And we think about this as cohort analysis, and we'll get into a little bit more of that in a moment. But, there are all kinds of ways we think about cohorts. So, for example, there's been in the last few years a lot of focus on superutilizers. These are people sometimes called frequent flyer, which I think is a terrible name. But just people, a small group of people, 5% usually in Medicaid, who account for over half of the total expenditures of dollars. Even that 1% that seeks a lot of services in very high-cost settings, totaling about 25% of the dollars. And a lot of clinical management programming is aimed at people who use disproportionately. But that's not the only cohort you can go after So, for example, dentist, you're running a dental business here. One of the things you mentioned last time was working with mothers or expectant women, because when their prenatal care, including good oral hygiene, are improved, there are reduced adverse outcomes in the childbirth phase of things. So, don't just think about this as the go-to spot is the super utilizers, because payers always or usually want to reduce total cost of care. But there are other ways of thinking about and developing clinical management programming for different cohorts. Make sense? Can you start to envision within your patients different types of cohorts that you might link together because they have a common set of characteristics, and you could envision doing something standard, repeatable, consistently that would lower their overall cost of care and improve their health outcomes? Okay, so how do you actually develop a clinical care management program? Well, there are really 5 steps as we think about it. Understanding your contract and using your contract, or if you don't have a contract, what are your goals for your programming, any programming? And as good safety net providers who have written tons of grant applications in the past, you guys understand how to articulate goals for a program, and hopefully how to make those goals measurable. And in terms of your payers, they want to see cost reductions, quality improvements, and improved satisfaction. And it's up to you to figure out more specifically what that means and how you're going to measure it. Then your cohort analysis comes into place here. Given your goals, what do you think is the population you need to serve in order to meet your goals? And how are you going to identify people in that population? We call that identification of risk, and we call it also population stratification. So you may have heard the term ID strat bandied around. Fancy term, all it means is who needs what, or who needs something different from what they're currently just getting today, which is straight services. So then the third step in all of this is really defining the interventions for those cohorts that you think are in need of something different to help you and your payer meet shared objectives. And the defining interventions get to be more art than science. And this is where we tend to iterate a lot. And I think, Carol's case study of emergency department reduction management, she will talk through a case study, and you'll see that this is the place where you make a lot of assumptions, and you test those assumptions rigorously, and you get prepared to make changes as you go. Because as you're doing this, you're implementing and monitoring progress towards the goals for that cohort. And then you're evaluating and you're adjusting as you go along. What you identify as measurable goals as you identify them is not just the outcomes, but what you expect to see along the way. And some of those can be process-type measures. For example, if you have a protocol you're implementing to improve 7-day follow-up appointments for people who have gone to the ED, you will want to know ultimately, okay, are people really coming in within 7 days? And does that 7-day appointment really help reduce subsequent visits to the ED? Those are the outcomes. But along the way, you'll want to know things like, okay, if I call them within 24 hours of their visit, and I get that appointment scheduled, and I call them 2 more times, and I send an email message, are those are my interventions? Am I executing on my interventions? And even if I'm executing on my interventions, I may not get the outcomes I expect. So I'm going to look at both as I go along my journey of figuring out how to reduce the amount of emergency room visits for a certain cohort or population. Does that make sense?
Yes, that's me.
Okay. My guess is you've used a method very similar to this to write a grant or develop another type of program. Is there anybody who's unfamiliar with this method? And do your organizations all have kind of quality improvement resources that can be pulled in to help you with the evaluation?
Yes, we do.
Okay. And okay. And the other thing, Sarah, and I'm glad you're on this phone, on this call, because this tends to have pretty significant implications for obtaining and working with data as well. And we're going to talk a little bit more about that in just a minute. But we kind of meet two different types of organizations. There are organizations that feel like they're just drowning in data but don't really have insights. And there are organizations who would characterize the problem as, oh my gosh, we just get no information. We have no data. We don't even know how to access data. So, I would wonder which of those buckets you fit in, and if there's somebody who has a different experience, let us know. Do you feel like you're more kind of data-rich, information poor, or you just don't even know how to access the data?
Oh, we are data-rich, and we know how to access it. So a lot of this, I think we've identified groups, high-risk consumers and so on for Susie already. So I think, this shouldn't be a problem for us. Generate this kind of information shouldn't be a problem at all.
Okay. Little tip, it's easier to start with the end in mind. I mean, they're not just the goals, but, really being clear about what you want to see along the journey, how you will be making progress, and defining those in very concrete terms. And then the intervention just takes a whole lot of creativity, frankly, and trial and error, so be prepared for trial and error. So we think of ideas and strat usually as finding needles in haystacks. There are a number of methods you can use to identify cohorts and start to think about and understand what those cohorts need to have experienced reduced total cost of care and improved outcomes. None of them are perfect. We usually recommend some combination of methods. Some of these methods, risk analysis, predictive modeling, are more expensive. Some of them are less expensive. For example, clinical judgment. They're more or less reliable. None of them is perfect. Nobody has a crystal ball. And so we go back to, be willing to and tolerant of making mistakes and thinking about how to iterate rapidly and in a very controlled way, and maybe think of piloting before you contemplate huge scale. So we're going to talk through briefly all of these analytics methods. We'll start with risk analysis and predictive modeling, and then talk a little bit about each of these as we go. And please stop if there are questions. So no two people are alike. We talk a lot about big data in this industry called healthcare, and I think some of us, including us at Optum, might be a bit precious about big data and how wonderful and important it is. More and more we realize that little data is important because no two people are the same. So even though they're in a cohort, and here we're talking about patient A, patient B, both male, roughly the same age, both live with diabetes, type 2 diabetes specifically. Both have had their hemoglobin A1C taken within the last year. That's good. Hemoglobin A1C is a little out of standard, meaning they have diabetes. There are some visits, multiple outpatient visits. Patient A here had a hospitalization 6 months ago for acute myocardial infarction, heart attack. And prior year's cost for patient A was $21,700. Patient B, prior year cost $25,400. And so in the past, many of us have said, well, we want to see all patients where we think they've spent over $20,000 or over $25,000, or maybe we even get, depending on the population, the Medicare population, maybe over $50,000. And we think, well, if they were expensive last year, they're going to be expensive this year or next year. How good do you think that assumption is? If you were going to pick one of these for a diabetic management program, which one of these patients would you pick and why?
This is Susie. I would probably pick A because of the multiple health conditions. When we're looking at people, I'm in behavioral health, so we tend to not look at the previous year's cost, because we find that a lot of our patients, the disease is cyclical in nature, so you might see someone one year. That doesn't mean they're going to be expensive the following year, just because of the way the crisis and the disease works. But we look at things like multiple chronic conditions. Those are just some of the guidelines we use.
Okay. Anybody else? Who would you pick? Scarce resources, you can only case manage or clinically manage one person. Which one would you pick?
Probably patient A, because of already having had a heart attack.
Okay.
Would lead to greater microvascular changes, possibly leading to further complications faster than the other patient.
The only thing, this is Jennifer, the only thing that jumps out at me is that we haven't done a hemoglobin A1C on patient B for over 9 months.
Me too.
And so I'm a little more worried about that person because they're not as connected. They've had multiple outpatient visits. And actually their totals are even higher than the total for a guy who was hospitalized for an AMI, which is interesting. It makes me wonder what else is going on with that one.
Is outpatient visits ED visits, or is it clinic visits? What's the definition of that?
Let's say outpatient includes ED and specialists. Good question, though. Very good question. Okay, so let's see what happened. You get a little more information, you get a little more insight. And so in this case, these are 2 patients we ran through a predictive model. In our case, we have one I quite like called Impact Pro. I like it because it gives me not only risk scores retrospectively, but it gives me prospective risk scores, and I know that it takes out things like, okay, if you incurred a lot of costs, going back to this notion of cost here, but you incurred those costs as a result of a motorcycle accident and subsequent physical therapy. That's different from incurring those costs because you have a chronic condition and it's not being very well managed, and your ability to advocate for yourself and form the kinds of healthcare relationships you need to more proactively manage your condition doesn't exist. So in this case, those of you who said patient A was higher risk, you were right for exactly the reasons that you identified. Even though patient B was more expensive last year, they're going to be way less expensive. Their predicted costs for this year are $15,000 versus $34,000. And so this is what good risk analytics can do for you. It can tease out more of those clinical conditions. It can start to look at the completeness of care or incompleteness of care, inferring whether or not there's a good primary care relationship, and you get a better sense of risk because you're looking at more aspects of each patient profile versus just total cost of care historical. So that's what good risk analytics engines do. They take data from lots of different sources, including in some cases self-entered, because what a patient tells you about themselves can be quite important. They may tell you in the clinical setting, it may be in your EMR, it may not be. But our sense is that the more information you can put together about a patient, the more likely you are to have good insights about what it is they need and find a more granular basis for creating cohorts with common sets of needs. And the more streamlined you can be and precise you can be about your resulting interventions that are part of clinical management. So basically, what these good analytic engines are doing are putting together patient-centered profiles from lots of different information sources. They're spitting out or imputing risk of future costs. It can be risks of hospitalization. It can be risks of future ED use. It can be types of service utilization. For example, Impact Pro is able to distinguish between likelihood of medical utilization and identification of future behavioral health service use and related costs. So you have to think about what it is you're trying to find, why you're trying to find it, and then what you're going to do with it. What I like about Impact Pro is that it has clinical indicators, care opportunities, meaning part of what affects risks is the lack of care sometimes. Good outcomes, clinical outcomes, aren't just about withholding care. We think they squarely point to and require better preventive and primary care, including mental health services and dental. So, look for engines that also help you identify good care opportunities. You can sometimes call them gaps in care, that you understand what they are and you understand what you're going to do about them. So that's sort of predictive modeling, very quick overview. If anybody wants more detail on different types of predictive models, there are some very common ones in the industry. There are some free ones or free to public entities, including CDPS. That's the Chronic Disability Payment System, I believe. It was created by the University of California, San Diego. There are some paid ones where public entities pay slightly less, though. For example, the Hopkins Group, or otherwise known as ACG. States are increasingly using these, and payers have used these for a long time to underwrite business. But they're also, just with using claims information, some decent clinical insights you can get out of this type of analysis that will help you understand what you need to do from a clinical management programming standpoint. So another way of doing ID and Strat is health risk assessments. There's some caveats there, and I start with the last one. Look for validated instruments. It's very tempting to just sort of send a group of people to the table in the break room or a conference room and just have them knock something out in a couple of hours based on clinical judgment, which, it isn't always bad. But resist the temptation to stop there. At least do some of your own validation and refine that assessment over time as you apply it and learn more. More better is to get a validated instrument on the market. There are even some free ones. For example, PHQ-9 is free. Those of you in behavioral health, PHQ-9 helps identify risks associated with depression and anxiety specifically. May not be the only assessment you want to use, but at least there are some free ones out there. Look for good validated ones. The SF-12 is and the SF-36 made by Quality Metric is kind of the gold standard. Another one that's very popular and very well validated is the PAM, Patient Activation Measurement Instrument. It's created out of, I think, a doc at the University of Oregon, and now I think it's privately owned, but it's still low cost to publicly funded entities. Some other things to keep in mind: settle for the bare minimum. What's the information you need to make a decision? There's a tendency, especially among payers, to ask a bazillion questions because there's so much, as payers, we don't understand about patients. We don't see them every day like you do. And, it's easy to ask what we want, ask a lot of questions and to always get more information. People don't sit still for a lot of questions, though. They get irritated when you ask them things they think you should already know. So really be disciplined about getting the bare minimum and try to reuse as much data as you already have access to. For example, if you have a meaningful use patient portal and you're asking patients for information, assessment information, figure out how to get that in front of your clinicians, your care managers, or whoever is going to be performing interventions before you decide that you need to ask patients again for something. Has anybody worked with health assessments, risk assessments, and would offer any other additional insights? Okay. Other methods for ID and strat, looking at utilization. The numbers matter, so you may decide you're going to focus on people who use the ED a lot, specifically for ambulatory care-sensitive conditions. Payers are good sources of utilization data. They love utilization data. They don't always love to share it, but if you're in value-based arrangements, that's a gotta-have. Demographics. About 30 to 40% of what drives risk in our models is age, gender, and zip code. So those seem like simple things, but they matter. If you just use demographics, though, you can get many false positives. Everyone over 65 in this zip code, the cruder your analysis, the more false positives you're going to have. Clinical judgment. You get a lot of, at least if you're going to use clinical judgment, get your clinicians to agree on and negotiate a defined set of criteria versus asking each of them independently and relying on simple anecdotal judgment. There are social determinants of health, which increasingly we collect more information about. Big buzz phrase. Problem with social determinants of health is we don't always know exactly what to do about them. So there gets to be the sense that they're very important, and they are. We see that in the patients we deal with. But what is it we're actually going to do? So in thinking about your ID and strat, you'd love to solve for world peace. On the other hand, you've got to be practical about what you can and can't do, given your resources, what you do and don't know about patients. So all of these are methods for learning more about and identifying cohorts and deciding what it is those cohorts need. They all have pros, they all have cons. Use a couple of them in combination if you can. Carol, I'm going to turn it over to you now. The importance of what Carol is going to tell you is along the lines of our 5 steps in creating clinical management program, and she's going to describe a clinical management program aspect and what went well and what didn't go so well, and leave it at that.
Okay, I get the fun part, guys. I get to tell you about a real-life scenario. So we get the theory in the presentation, and then we'll tell you how we applied it in a real-life situation. We had the opportunity. We worked with an organization. It was provider-led. It was comprised of 4 different hospitals, their corresponding medical groups, and a group of 6 FQHCs. Some were single-site FQHCs. Other had, a bunch of clinics associated with it. To give you a little bit of the history, the organization came together in response to there were government funding initiatives in the state, and the group came together because they saw it as a great opportunity as they were going to be reimbursed fee for service plus a care coordination fee. Because they were a new entity, they didn't want to take on too much, which was smart. They had decided the case management function was going to be focused on high and moderate patients, and they were going to contract it out to a local Medicaid health plan. Let them do it. They had a lot of experience doing it. That started out okay, but there were some performance issues, so the entity brought the care management function back in-house. So there were a lot of changes, and the state then ran into a funding crisis, and they said, no more of this fee-for-service and a care coordination fee. You got to become either an MCO, a managed care organization, or align yourself with one. So the organization picked an MCO to align with. So there are a lot of different things going on. In the meantime, they were taking care of these patients in a care coordination model, but the state, because their financial situation was very slow to pay claims, and because of that, the claims data that we had was so far behind, it was like worthless. But that's the data we had to work with. So the risk stratification of the population really did not reflect what the patient's status really was. So when care managers began to outreach to the identified patients, we found that the information was so old they had relatively few current issues and couldn't figure out why we were calling. So it was not a good scene. In the meantime, an opportunity jumped out at us, and our whole session today is identifying your cohort and picking who the high-risk ones are, because you can't help everybody. But a hospital partner, it happened to be a pediatric hospital, was evolving their ER program, and they wanted to partner with us. And they said, hey, why don't we share the patient-specific data with you it was usually like a day or two after they went to the ER. And we had this great idea as a team. As Natalie said, we sat around the cafeteria table and we came up with a plan to, hey, we're going to make sure we have appropriate ER use. At least that's what we thought our plan was going to be. And we were only going to be able to do this for 2 months because then the MCO that our entity had contracted with, their contract started and they had their own ER diversion program. So that's what we had to work with. And let me ask you guys, what would you do? What would you see as an opportunity? What would you do if this was your organization? I'm throwing it out there. Ideas?
So when you ask for ideas, if it was our organization, specifically, are you asking for ideas to decrease the ED utilization or negotiation? Or I'm sorry, I missed that.
No problem. No problem. If you were presented with this opportunity, a hospital is saying, look, we're going to give you the ER list. So one would think that these are high-risk patients, right? They went to the emergency room. What would you do with that information? How would you proceed?
So my hospitals currently give me that information, and what I do is I look at the reasons for the ED visits, and then I really look for their association with a primary care provider in the area, and I have contracts with each one of those primary care providers, so I can look at specific records to see if they meet kind of criteria for us to case manage for them. So I would dig deeper into why they're going to the ED, what the codes are for their visits to the ED.
Okay. Excellent. So you'd look for the reason for the visit, just to give you a little more information. We did not get any codes for the visit. We just had an admitting diagnosis and a discharge diagnosis. But you're right, that's a really good data set to know. You'd look to see if the patient was aligned already with one of your PCPs, and you'd look to see if they would fit based on your criteria with your care management program?
Correct. And then the other place I look is we have a data shared point where folks that are using other social service agencies, all the data we have access to, so I can identify what other social service agencies maybe they're aligned with in the area, because that really helps give us a lot of good insight.
Oh, that's terrific. Does anybody else have that resource? It's sort of an evolving thing.
Yeah, this is Renee from Cascadia, and we're fortunate that we also have a lot of access to data. And kind of looking at the scenario, I guess through my role, I would look for trends across the population. Like I think about not only our organization as a population of clients, but looking, breaking that down by site and program. And what that would allow me to do is if we had a number of individuals who had some type of diagnosis of diabetes or who were admitted to the hospital for, something diabetes related, I could target and develop my interventions for the particular clinic or sites that need it and really kind of do population-based treatment and even take that a step further and think about health disparities and inequities and providing culturally appropriate treatment services.
Oh, that's excellent. So looking at that as a data source, identifying any trends, and then looking to see what interventions and looking any of the social determinants, cultural influences, et cetera. Excellent, excellent. Anybody else? There's no right or wrong. What would you see? What would you do? Okay, let's move on. We'll tell you what we did. We were given this opportunity, and we saw it as a great opportunity. You get an ER list. This is a high-risk population, right? These are your high-risk, your costly patients. It came in the nick of time because our staff, our care coordinators, were making outbound calls. They started out in the office, then they moved. It was a mixed model. They were also in the field. But as I said, the data was so old, they were making calls to patients, and the patients had no need. So they were very, very frustrated reaching out to members with no needs. So they were very excited about the opportunity to work with real-time cases. We created an ER program. It's not the purpose of this call, but we put together some structure. We, just like, I don't know who talked, but just like you would look to see if your patient was aligned with a PCP, we did that. So thank you for that suggestion. We looked to see if the patient was assigned to one of our PCP, and we called out based on that PCP assignment. If not, we got them affiliated with an organization. Sort of a find that we got that we were not anticipating was that the numbers that we outreach to, this was a gem, unexpected, but a hidden gem. Because these people had just taken their kids to the emergency room, they usually gave good phone numbers to the ER staff. These were concerned parents, caregivers. They wanted to be accessible. So we found that when we called the numbers, we had really good hit rates, and we reached them. So we were able to capture those numbers in our EMR system. And another thing was we then tweaked our EMR system to add an additional field where we could document phone numbers. Because if you've ever done outreach, you may be familiar that sometimes people have a lot of phones or their phones turn over. So that was an unexpected little gem. When we reached out to folks, we found that we usually got the folks, and if they didn't, they called us back. Which, if you've ever done a telephonic model of case management, your reach rates can sometimes be less than you had hoped for. But we got them at the teachable moment. They were concerned about their kids, and they called us back. A limitation was the population was skewed. It was just a children's hospital, so we didn't have any adults. But what we found, again, another little gem, was in anticipation of our population, 100% of our population coming to us for care management in 2 months, we found that we needed to hire more pediatric care managers, nurses, and social workers. We didn't have a lot of those. Again, we were looking to decrease ER use, but all these little gems came up that we discovered. The other thing that we discovered in doing this was we knew that the population, there was going to be language issues, cultural differences. We did not anticipate the number of, just for this population at least, Spanish-speaking and Arabic-speaking. The state gives us a file, and it explained who the population was. Rarely, if ever, did it say that they spoke a different language, and if they did, it would be Spanish. But then we would find it would be an Arabic-speaking person, not Spanish, so we'd have the translator on the line ready to go with Spanish. So it's a very helpful lesson learned. We also learned how to work with interpreters. Again, nothing to do with working with a high-risk population, but we went on this journey with high risk and reaching out to them, and we learned different lessons. And it's a real skill. If you've worked with interpreters, it usually takes double the time during the interaction, and there are interpreters and there are interpreters. We got into a little bit of program design issues and philosophy of care. We talked about, Natalie referenced, your ER people making sure that they have 7-day follow-up appointments. Well, we got into something that we had never drilled down into before. Who should make those 7-day follow-up appointments? Hopefully the ER has taught the patient to make that follow-up appointment, but in outreach, if we've not made that follow-up call, should we be doing it for our member? Should we be doing it with our member, or should we trust them to do it? So it was sort of a discussion back and forth, philosophy of care, and what our motto would be. There were different things. In the interest of time, I won't go them in, that we learned. People, we wanted to review their discharge instructions. They could never find those discharge instructions. Medication review. But it also gave us the opportunity to educate in terms of when do you use the ER versus when do you use other alternatives. Again, we went on this venture thinking this is a high-risk population, and they went to the ER. Well, not all the time. This high-risk population was not necessarily always a high-risk population. What we found was that sometimes there were cultural influences, that people were used to going to emergency rooms. They had no experience. They didn't understand the new benefits afforded to them. They did not know that there were on-call doctors, or even that their clinics had weekend hours or open access. So we made a lot of mistakes. Again, we jumped in at the opportunity. Natalie likes to say, don't let perfect get in your way of getting off to a good start. In our quest to do good, we started reaching out, and again, I mentioned we had different partners. We shared the information about the ER outreach, so the provider would understand what had occurred, but some of the providers we found had already done outreach or were going to do outreach, so we kind of stepped on their toes, which is not a great way to form a relationship, but I think we found that people were aligned. Our goal was to prevent ER use, ER use only when indicated, and we learned so many other valuable lessons. So quickly, how did we use this opportunity to identify a high-risk population? We used the data that was available to us. People on this call, it seems like several of you mentioned you won't have any problems getting data. Data was an issue for us. So we used what we had, and that was real-time ER. And like I said, it wasn't always high-risk sorts of things, but we used what was available. So I think the lesson is, don't get into analysis paralysis. Use what you've got, make a plan, and go back, measure, and retweak your plan as needed. We followed the money. ERs are expensive. So we thought, here's a high-risk population. They're going to the ER, and if the ER is necessary, great. But we found a lot of colds, temps that did not necessitate, that sort of thing that we were able to do some education on to save the dollar. When we got the list of patients, an ER patient is an ER patient is an ER patient. Well, that's not true. We identified different cohorts, if you will, between our population. As I mentioned, we had different language issues, and people's, not only the language they spoke, but the experience and the expectation of where you go for care. Transportation we identified as an issue, and our program actually had a transportation benefit. People had no clue about that. So by sharing them that there was transportation benefit, they no longer had to wait till, their husband came home from working second shift and took their kid to the ER at 1 a.m. They could make the appointment with the PCP and arrange transportation. And I mentioned earlier, there was a whole new cohort of people who'd never had health insurance before, had no idea how to use it, and just an opportunity afforded itself. So bottom line, the lesson I think is don't let perfect get in the way of doing a good job. You know, our goal was to, we were going to, shake the world up and cut ERUs and cut down the, Natalie hates frequent flyers, but those people who overutilize it. But I think what we got out of it instead was we truly increased our engagement rates. Because as I said, we had good phone numbers. We had the willingness to be engaged, and we were with the families when they needed the family after an event that then we could intervene. There were other lessons learned for patients that we learned. Again, while we're identifying a cohort, we learned that there were preferential hospitals they liked and why they liked one hospital over the other. They may travel to different hospitals. So again, we were a system, we were an entity of 4 different hospitals, so we were then able to use that information to help our hospitals improve if they needed that information. I alluded to earlier, people sometimes use the ER because of lack of understanding. I talked about the Medicaid benefit knowledge. I think patient satisfaction truly increased as well. Again, we were there when they needed us to be there, rather than using the data that we had, which we needed to use, old claims data, but it was old, it was no good, and frankly, we were annoying people calling them. So I think the lessons learned for the session today was utilize the data you have, identify the health risks inherent in the population. When we went with the managed care plan, we had, I think, 36 different tools, different assessment tools. It took 2.5 hours. People got frustrated with all the assessments. We got a lot of information in a short period of time, and we were able to identify their health risks. And again, an appreciation of the demographics of the population we were dealing with. So again, don't let perfect get in the way of being willing to start and do something different, because we did do good work. We made a difference. Okay, any questions, any comments? People still there?
Yeah, you guys did a great job.
It wasn't perfect. We could have done better, but we started and we learned.
I did write down that quote, that you didn't let perfect in the way of a good job. I've got that one down.
And you can attribute that to Natalie. Really, don't be scared to move. You know, you start out with a goal. You do your best, you measure, and you come back.
So I work for a larger institution, and so in my little life world, I have selected our utilizers of, I get lists from my ED department, and those who are patients of my clinic for family medicine, our family medicine clinic, I provide services for, and we've seen significant decreases in their ED rates and in their engagement and those types of things. And I do it on the side for some of the hospitals just because that's kind of our community benefit piece back to our hospitals for good relationships. I've not been able to get my folks at my higher up in my institution to take that back to the insurance companies and negotiate or talk about coverage or payments for that. And both hospitals are telling me that we should have those conversations, and just 60 or 90 miles from me, those conversations are occurring with the insurance companies, and they're getting coverage for things. And so I'm just wondering how to kind of make that next step happen, because I'm kind of stuck since I'm at I'm kind of under somebody else to make those negotiations with insurance companies.
I have one thought, and Natalie probably has a more of a strategy. One of the things that we did just by accident was our CEO was very, very, very supportive, but was busy, was everywhere. And she really believed in our model, believed in what we were trying to do. She loved hearing the stories. And not that, we touched a patient, but we told her the specific stories of, how somebody went to the ER because they didn't have a thermometer, or somebody went to the ER because, or they didn't make a 7-day follow-up appointment because the ER told them to wait 7 days, call the doctor at 7 days, and then, you can't get an appointment right away, so then it's 2 weeks before they get in. So those stories that make it come alive. And I would, that's a simple thing, but also allowing your leadership to, and I'm not as familiar, somebody mentioned the public health, I forget the CFR or whatever that reg was for PHI, but listening into some of the interactions with your staff to let them see and hear. Sharing data is wonderful, and sharing how it sounds like you've met some of your metrics. You've cut admissions down. You're saving dollars, I'm sure, but to tell some of the human interest story and let them experience that, I think that's very, very powerful. That sometimes doesn't come across in a pie chart or a bar graph. Natalie, do you have any comment?
Well, I was wondering, I think Carol's right. Different people digest information in different ways. And, the stories that we told the CEO, I think, got her attention. I wonder, how you're also structuring it. I mean, you said this reduces future ED visits in that cohort. What does your data look like? I find it hard to imagine not being interested in a 5 or 10 or 15% reduction in ED use.
So our hospitals are, and they fund me.
Mm-hmm. Yeah.
But I haven't gotten, and I don't know if it's because we're kind of in Illinois and it's a really bad area to do any kind of negotiations with anything right now, with no state budget and everything else. But that's kind of getting in the way. Do you know what I'm saying? Or what? And we've had we've had a lot of changes here at the institution. So I guess I was just wondering if, and we, I have told the stories. They've, the newspapers have ran stories on it. Our local journal did a whole series of coverage of this and stuff. I'm just kind of getting frustrated because I'm trying to figure out how to get that next step with the insurance companies. And we are demonstrating in some of my highest utilizers that nobody else in the area has wanted to care for, which is often my homeless patients with mental illness. We have demonstrated a 22% ED visit rate with very few interventions. It's really just a case management social connection piece for a lot of those folks and getting them access. And so I guess that's kind of where I'm struggling, is trying to figure that out. And one patient last year, we measured the direct costs, and the hospitals have done this for me, and we had over a $64,000 reduction in just that one patient. And we managed patients like that. That's where I'm struggling.
Oh, I can see. Yeah, man, can we come visit and figure out what you do? I mean, that's phenomenal. And so a couple of things. In Illinois, yes, hospitals and Medicaid are struggling with a bunch of new payers. You're more downstate, so you're kind of maybe more, your hospitals might be more used to managed care companies and Medicaid. Is that right?
Well, I'm central Illinois.
Central, okay.
I'm not Chicago, and I'm not down southern, so I'm just really kind of in the central. But yes, they're interested. They have had a lot of relationships with, kind of the organizations.
I'm struck that your payers aren't knocking on the door. I mean, there are entities that we work with in the Chicago area, and I feel like some of these providers can't beat these payers off with a stick. They're so interested in, they've got a 2% premium withhold tied to quality. They're dying to get utilization down. Is the hospital not in a financial arrangement with the payer that makes it worth scaling this? Is that the problem?
So the hospitals, and this is what I almost in some ways, I'm thinking that the hospitals are benefiting from my work, and I'm not employed by the hospitals. I'm employed by our academic center that's connected with. And so, of course, then, they've given me funds for a project we do in the area, but it's not long-term support that I need to have negotiated to maintain my community health workers. And you know what I'm trying to say? So they've been generous in giving us some funds, but there's no continued sustainability promise.
Right, but is the hospital's contract with their payers, you know, is it ultimately not worth their, you know, given their payer mix, is it against their self-interest longer term to do a whole lot more and to make this sustainable, scalable? Is that the problem? And the hospitals are unable to get into total cost of care?
No, I don't think so. Because when I meet with the hospitals, they're very engaged. But my billing has to come through my clinic settings. So, and we're not associated with the hospitals. So I think that's the delay here. Do you know what I'm saying? The hospitals are very much about this. But our academic center hasn't had those negotiations with the payers into my clinic itself.
Do you see it perhaps as a revenue opportunity for you guys, that maybe you generate a proposal that could be taken up, that, you know, you take this on, a long-standing commitment, a commitment of how many years, and gain sharing, and it would bring this amount of revenue in? Would that catch any attention?
Yes, I think it would, and I guess I feel like I don't have the skill sets for all that, and I've been trying to work with our larger institution to build that or figure out who's the next step, and that's just where I don't have that next skill set to do.
And this is the lady who I was impressed with early on in the call that reached out to her hospital CFO, right, to get his or her input on the contract?
Correct.
So you may have limitations, but you're very resourceful.
Okay.
I applaud you for that.
I'm not heading down a wrong direction when I'm thinking of these ways, and, you know, and we're tracking them. We even have relationships with CMS here, so I can get that cost analysis data, so I can start to look at, you know, I mean, I've done all these negotiations to get all this data, and now I'm sitting here, I don't know the next step. So I think just kind of hearing that, yes, I'm moving in the right direction is probably really good.
Could we call you offline and talk about it?
Yeah.
You know, it also, I mean, when you say CMS is aligned, does that mean it's Medicare?
Yeah.
Okay, different kettle of fish.
Right. Well, but we also Medicaid, so we're able to get some of the Medicaid data. So yeah, if you wanted to, I have meetings right after this, but maybe sometime we can take the time to talk. That would be great.
Okay.
Thanks.
All right. Do you want to get onto you?
I was going to say, why don't we do that? We're going to move you around. Do you want to review homework, Natalie, for next week?
Why don't you go ahead and do it, Carol?
Okay. So your homework for next week is we need you to, or excuse me, 2 weeks from now, is to consider what data sources you have in your organization right now. A couple of you said you're very rich in data. You know, write them down. And let's say if you could have any data source in the world, and you need them to find, you know, your high-risk patients, your cohort, those that use your expensive services. What would you want, and why would you want that data? Then from there, if you consider what are the 3 most important data sources you have to help you identify the people with high-risk needs, the expensive services. Don't spend more than an hour. If you get stuck, shoot me an email. Thank you, Dennis. Hats off to you. You shot an email. Hopefully we took care of your need. We welcome this. It's a learning collaborative. And one other, any questions on the homework?
No.
Yeah. The idea is, you know, we want you to define for your practice what you think a high-risk cohort would look like. What characteristics? Why are they high risk? You know, why are they using expensive services? What makes them high risk? And what information do you need to get to know much more about them versus what information do you have is essentially what the assignment is. Does that make sense?
Yeah.
Okay, it's just an exercise.
Before we sign off, I want to remind folks, if you'd look in the notes section of this webinar, at the close of the webinar, if you could complete the SurveyMonkey evaluation tool. We really want to make sure that these sessions are meeting your needs. So it's anonymous, but if we get your honest feedback, we'd like to be able to meet your needs and understand where y'all are coming from. So please complete the SurveyMonkey. All right, with that, signing off. Our next session is July 12th. If you have any issues before, send me an email, and look forward to talking to everybody in July. Have a great 4th of July weekend.
Thank
Bye-bye.
you. Bye.
Bye. Thank you.
Bye-bye.